everyone, and welcome to today's webinar. We are going to be talking about reimbursement strategies for employers of community health workers. Glad that you can join us. All right, just covering the agenda kind of briefly. We want to go through intros, kind of who's here, recognize the work that's been done, the importance of this toolkit, a little bit of the background of the collaborative, overviewing the strategies, the different strategies for employers that we'll be presenting, as well as a case scenario with Dr. Solano. All right, and like I said, I'm Hanaid. I'll here with Mid-America Regional Council. I'm a CHW project manager, and I will be your host. We also have Erica Zaleski, who is a consultant with more than 15 years experience in public policy research and analysis. Erica led public policy development for the Office Management and Budget and has supported the collaborative since 2015. We also have Timothy McNeil. He's an independent healthcare consultant specializing in healthcare development and sustainability. His customers have included the U.S. Department of Health and Human Services, Administration for Community Living, and the National Association of Area Agencies on Aging, the National Council on Aging, and various foundations and national nonprofits. We also have Dr. Solano. He is a director of behavioral health at Samuel Rogers Health Center and has held leadership positions in different organizations in the Kansas City metro area, including advisory committees in city, county, and state levels. He has extensive experience teaching, directing, managing, and implementing programs in community, educational, and healthcare settings. Before we move forward, we want to do some recognitions. So this was developed and then written by Erica Zaleski from ES Advisors and Tim McNeil from Freedmen's Health. Advisory Committee provided strategic guidance on content. Outside reviewers advised on accuracy and completeness of content, supported with funding from the Health Forward Foundation, and supported by Mid-America Regional Council. All right, so
Hanaid, I can talk a little bit about the importance of this toolkit and why it's so critical that we developed and are releasing it today to our community. We know that the healthcare system is slowly moving towards addressing social drivers of health. So those social barriers that our clients face that impact them from achieving their best healthy life and health outcomes. And community health workers are critical to helping address social drivers of health. They're critical to improving health outcomes, quality of care, and reducing cost. Neither Missouri nor Kansas Medicaid have a unique reimbursement recognizing the scope of work of community health workers. And so we realize that we need to look at opportunities to sustain community health workers within the existing healthcare system. So are there reimbursement opportunities that we can leverage and help our organizations and our community leverage to reduce reliance on grant funding and help to sustain community health workers long-term? And so that's why this toolkit is so important, and we're so happy to release it today. Next slide, please.
Thank you, Erica. So throughout the toolkit, I know this is a webinar, but we're going to try to make it really interactive. We're glad that everyone is here. We have this tool. I'm not sure that if folks are familiar with it. It's called Slido. So you can use your phone. So if you scan the QR code on the screen, you'll be able to see a URL pop up on your phone. You can open it. And as we go through the webinar, we're going to have different questions that we're going to be asking the audience, and we'd love to hear more from you. And we want to know kind of where you're from, what you're doing, what are your interests. So throughout the webinar, you'll see questions pop up. We want to know what you're doing. And if you don't want to use a QR code, you can also use a link. We can put the link on the chat. And the hashtag for that is toolkit. So again, I know that webinar is sometimes a little bit different because we're not with each other, but we do want to make sure that we have your questions addressed and that we're able to hear from you, even if it's remotely and digital. All right, so everyone, as long as you scan that code and you can see the questions pop up on your phone. And as we go through the questions, you'll see the same questions that are going to be on our screen on your phone. Awesome. So the first question, if you scan the QR code, it's going to be share your city and state. So where are folks joining us from today? Where are you participating from? All right, New Madrid. And you can see that we have 18 folks typing. So let's give a few more seconds there. Seems like Missouri is the #1 state being represented, Kansas City, followed by Columbia, Missouri. All right, we still have a few more people. Thank you for responding. So Kansas City, Columbia. Yeah, Missouri. So a lot of Missouri folks are here. I'm trying to see, it's jumping all over the place, but I see Pittsburgh and Pineville, Lexington. I see someone in the chat say St. Louis, Dodge City. Awesome. All right, St. Louis. All right, next question. So what type of organization do you represent? Again, you can scan the QR code, and this one is multiple choice. So if your organization has different, you have different types of services that you provide, you can respond to more than one. So again, you can use your camera on your phone to scan that QR code, or you can go to slido.com and enter the hashtag toolkit. And we just want to see who's here today. So it seems like majority of the folks that are here are community-based organizations, followed by FQHCs, then healthcare providers or practice group, hospitals, and MCOs. All right. Again, so this one is, how familiar are you with CHW work or Promotores de Salud and their scope of practice? So this one, you'll see 5 stars on your screen. 1 is the least familiar you are, and 5, the most familiar you are. So you can kind of rank how comfortable you feel with the scope of practice. Again, if you're just joining us right now, you can scan using your camera on your phone, the QR code, or the link in the chat, which is slido.com hashtag toolkit. So how familiar with the scope of practice? So it seems like majority of the folks here are at 56%, and overall the group who's been voting, we have a 4.3. So it seems like a lot of knowledge when it comes to CHW and Promotores de Salud. Awesome. So what is your role in your organization? So we have a lot of people joining us. And again, if you have different roles in your organization, this one too is multiple choice. So if you have 2 different types or more, you can select it. We also have others. So if you're a CHW or Promotora de Salud, an admin, a finance person, a clinical provider, you can select those through your camera. So it seems like most of the people on this call right now are administrators, followed by CHWs. Oh, we have a kind of a tie right now. CHWs and CHW supervisors are there. All right. So, and we see some other same things in the chat. All right, so then this is a part about Slido that's a little bit different. So we want to make sure that we get to hear your questions. And as our presenters are speaking and going through the toolkit, you might have a lot of questions that pop up. And since we're going to be presenting, what we want to do is go ahead and use Slido. Again, you can use your phone, scan that QR code, and have it ready on your phone, or open the link on the chat and use the hashtag toolkit. And as someone's presenting, you have questions. So if someone, let's say Erica's presenting on chapter 2, and there's a question on chapter 2 that you want to know a little bit more about, go ahead and type that question, and Slido will collect all these questions. So as we move on towards the end of our webinar and do our Q&A, we'll be able to gather those questions and go through them together. So again, as you have questions throughout the chapters, throughout the different slides that you'll be seeing, go ahead and enter those into the Slido and at any time, and we'll be able to review those towards the end of the webinar. And if you have any questions about how to use Slido, go ahead and put a question in the chat, and one of us will be able to help you on how to navigate that. All right, awesome. Thanks, everyone. Now I want to turn this back to Erica.
Hey, thank you, Hanaid. Before we dive into showing you the toolkit and talking about its contents, I want to take a moment to thank the KC Regional Community Health Worker Collaborative. This is a bi-state coalition that supports the growth and sustainability of community health workers. We've been working together since, I think, 2012 to help sustain and grow the profession in our bi-state region and in the states of Missouri and Kansas. It's a diverse partnership of many, many organizations, community health workers, community-based organizations, educators, and really without this partnership, we could not have produced this toolkit. And also without the Mid-America Regional Council support, they've really been providing backbone support for the collaborative, helping us develop capacity building in terms of training, continuing education, advocacy efforts to advance a certification for community health workers in both Missouri and Kansas, and helping to provide policy support to the collaborative. So it's really been a group effort, and so we thank everyone. I want to take a moment to mention, can we go back to the last slide, please? That this toolkit is grounded in the scope of work that was adopted by the collaborative and at the state level in Missouri and Kansas. And so that is critical because community health workers are the link between our communities and our clients and the health and human services system. And their scope of work is unique to serve in that role, to serve as that bridge and to help clients navigate and address community support planning and barriers to care. So I just wanted to make sure we kind of recognized that this is grounded in supporting and being respectful of that scope of work. Next slide. Okay, reimbursement strategies. During this section, we will highlight each chapter of the toolkit and give you an overview of what is included. Next slide. Okay, thank you. First, I'd like to just give you a visual overview of the toolkit. It was posted 2 days ago, I believe, at that link right there on the MARC website. We will share these slides so you'll have access to the link. And it can be found here on the MARC website. The reimbursement strategies for employers of community health workers, or toolkit, is the full toolkit with appendices. And then these toolkit Appendix C documents are critical documents, largely Medicare Learning Network guides that are referenced in Appendix C. Now we'll take a look at the toolkit. So it's a large toolkit. So we have a very detailed table of contents, and you can hyperlink to each section through the table of contents. We'll go to navigating the toolkit. In navigating the toolkit, this gives you an overview of what to find. So this toolkit was written for a broad audience, recognizing that there are many types of employers of community health workers. We have some organizations that employ community health workers that don't have a lot of expertise with healthcare billing in the healthcare reimbursement environment. And then we have employers of community health workers with very deep knowledge. And so we've included some chapters, the initial chapters, as a primer to healthcare funding and reimbursement to help orient all our readers. Chapter 1 talks about healthcare funding in the United States, major sources of funding. Chapter 2 talks about reimbursement to healthcare providers. Chapter 3 provides an overview of Centers for Medicare and Medicaid Services value-based care initiatives. Chapter 4 we'll talk about coding and billing for healthcare services. In Chapter 5, we will explore managed care opportunities. In Chapter 6, this provides a crosswalk of the different reimbursement models available. It consolidates everything we've shown so far. In Chapter 7, provide tips and tools for developing contract capture strategy for revenue sources. And then there are appendices A through L. Appendix A is a glossary of key terms, which will be important to reference. Appendix B provides a Medicare Advantage plan market share analysis. Appendix C is categories of services for multidisciplinary care teams with CHWPs. And this is a key appendix. The references are here, links to all our references, as well as the Medicare Learning Network guides that are also separately posted on the website. I won't go through the remaining appendices. We'll talk about them more in detail as we get into some of the more nitty-gritty of the toolkit, but I wanted to give you a nice visual of what to expect. So thank you. Okay. Key terms. Throughout this webinar, there are some key terms I wanted to highlight. CHWP, we will use this term to refer to community health workers and promotores de salud. Promotores de salud are health workers in Spanish-speaking communities. CHWP organization that is going to be used as a broad term for any type of employer of community health workers or CHWPs. It could be a clinical provider, a community-based organization, so it's a very broad term. Health plan and managed care organization, we will use those terms interchangeably. Healthcare provider, again, is going to be a broad term referencing any type of clinical provider. This could be an individual physician, a practice group, a hospital, a federally qualified health center, for example. Now, health-related social needs, that's a term we will use quite often. Health-related social needs refer to those social drivers of health, or those adverse barriers that are impacting someone attaining the best quality of life that they can, such as food insecurity or unstable housing, lack of transportation, childcare, all of those health-related social needs, those key factors that community CHWPs are adept at helping individuals address. And then finally, the term payer. This again is a broad term. It's going to refer to any type of entity that is responsible for funding the delivery of healthcare services. So it could be a health plan, it could be Medicare or Medicaid at the top level, for example. In chapter 1, this chapter again is a primer chapter. The objective is to help identify for the reader the major sources of healthcare revenue in the United States. So we'll look at the CMS, or the Centers for Medicare and Medicaid Services, as the largest payer of healthcare, with brief introductions to Medicare, Medicaid, and the state children's health insurance program. And then what is the health insurance exchange? What is the role of employer-sponsored insurance? And then we touch briefly on the role of managed care organizations in delivering and paying for healthcare for Medicare and Medicaid. In chapter 2, this talks about reimbursement structures, or how healthcare providers are paid to deliver care. Again, this is another primer chapter. This may not be useful for all of our readers, but for some that it may. And so we felt that it was important to first outline how reimbursement works. What are the payment structures for clinical providers to get paid for the care they deliver? And the key learnings, you'll learn about the continuum of reimbursement structures, from the traditional fee-for-service method, which reimburses for discrete delivery of services. So for each service that is delivered based upon a negotiated rate for the clinical provider. And then we will talk about the value-based care programs that are helping to shift away from payment models that emphasize quantity of services delivered, such as they do under fee-for-service, to payment structures that look at reimbursing for the quality and value of care that is provided. And we'll talk about pay for performance, looking at financial incentives for meeting quality indicators, for example, all the way through to there's greater risk as you move along the continuum for the provider. We'll look at a shared savings model. That means receiving savings for sharing in savings with the payer for improving quality of care and reducing costs. There are two-sided models where the healthcare organization may face a penalty if they don't meet cost and quality goals for a population of beneficiaries, or they could share in savings if they do meet those quality and cost goals. And then capitated payment is where an organization would receive one monthly set fee for all services delivered to a beneficiary. So they're fully responsible for cost and quality. And finally, the chapter will talk about the intersection of these models, how fee-for-service and value-based payment interact. And then Hanaid's going to facilitate our next poll.
Thank you, Erica. So the next question is for the group. And again, you can use either the Slido tool on your phone or going to slido.com using the hashtags toolkit. So the question that I have is, what type of support do CHWPs in your organization provide? Is it individual support, care coordination and community support planning, healthcare liaison, healthcare education, advocacy, or other? And this is going to be one of those questions where, again, you can select multiple choice if your CHWs have different roles. Again, you can use the camera on your phone to scan that QR code, or you can use the URL that we provided in the chat. So if you have different roles that your CHWs do and oversee a different program, you can do more than one. You can select more than one option. Just want to give folks a few seconds to respond. All right, so what type of support do your CHWs provide? So health education seems like it's huge. 80% of the folks here say that's what their CHWs provide. Individual support and care coordination and advocacy were all tied, followed by healthcare liaison. And I did see a message in the chat saying that all roles are covered. So the CHWPs provide all the roles all the options that we've provided. All right, and now for chapter 3, I'd like to invite Tim McNeil to start sharing.
Great, thank you so much. So in chapter 3, we really dive into the value-based payment initiatives. So we have a clear objective to identify many of the changes that have come out of the Centers for Medicare and Medicaid Innovation, commonly known as the Innovation Center. And so some of those initiatives are really driving change in healthcare. And CMMI, the Center for Medicare and Medicaid Innovation, they established their strategic pillars where they've identified that it is a strategic goal of that organization by 2030 to move 100% of the Medicare and Medicaid population into an accountable relationship with a provider. In order to do that, then it's very important for CHWP organizations to really understand the potential role of community health workers and promoters in the delivery system, particularly as it relates to addressing social drivers of health that will negatively impact the total cost of care and quality requirements that are key to success in a value-based payment arrangement. So we really use this chapter 3, to begin to outline the first 100,000-foot level. What are these initiatives, these value-based payment initiatives? And we have some of them listed here, such as accountable care organizations, episode-based payment initiatives like the bundled payment for care improvement model, Medicare Advantage payment models like the VBID, value-based insurance design model, and there's a newer model that's going to be launching soon called the ACO REACH model. And in each one of those models, there's increasing levels of risk that the provider's undertaking, and the goal generally is to improve both cost and quality. And when social drivers of health are negatively impacting cost and quality, oftentimes the role of the CHWP in achieving those objectives really becomes paramount to success. So we not only identify and provide information so you can fully understand what those alternative payment models are, how they fit into a value-based payment portfolio, but as well as the CHWP role in value-based care and how a multidisciplinary team approach to addressing those needs can lead to success, particularly if they're able to stratify the population based on needs and then deploy targeted interventions in community settings that can lower the total cost of care and improve outcomes when social drivers of health is a key contributing factor. Chapter 4 goes into some of the key requirements under coding and billing. And so we want to make sure that the user of the toolkit has a full understanding of what is this whole area, coding and billing, how coding and billing provides both descriptive information like Z codes, ICD-10 codes around diagnostic factors and identified social determinants of health, but also it also ties to billing, where you're able to capture an intervention that's provided. So that's very key to understanding the way that community health workers can be incorporated into the delivery system. One of the things that has been well adopted and used throughout the healthcare system is something called Incident 2, where Incident 2 rules allow for a person that's working under the supervision of a licensed provider to be able to help to deliver care to a population as part of a multidisciplinary approach to care. Many providers are very accustomed and aware of the incident to model, but how incident to rules can be used and leveraged to deploy community health worker interventions that are specifically tied to addressing the health-related social needs of a population. And an example of that, and we'll go into more examples, is when there's specific social drivers of health that may be, for example, impacting the ability to improve outcomes related to diabetes care. And a community health worker model could be incorporated into addressing behavioral issues, social issues that expand beyond the primary care setting into community, but are essential to driving the outcomes that are required. So some of those key learnings is understanding the claims, understanding how claims are filed and tracked at the beneficiary level, the incorporation of community health workers into the delivery model to meet the needs of the population also is a key aspect of the information provided in Chapter 4. Additional key learnings for this section really looks at the categories of services that can be delivered by CHWPs or unlicensed providers. And this is where we really dive into a greater understanding of the incident to rules. And one area that under Medicare regulations, which also applies to all Medicare Advantage plans because it's a rule that applies to Medicare Part B services, is that the incident to rules allow additional flexibility for things like chronic care management, where the incident to rules were modified to specifically allow for general supervision, which supports the delivery of targeted interventions outside of the four walls of a clinical setting. And so those key learnings will be provided, delivered, and then built into the practice model as a multidisciplinary care team. And then we highlight in that incident to rules some of the specific interventions that the incident to rules that support general supervision apply to, which include chronic care management, transitional care management, other behavioral health integration, which can impact a significant swath of a population that a provider is looking to address the needs for. Now I will provide an example of the application of that concept. So this detailed example will be provided, and you'll notice it in the toolkit. But a federally qualified health center is funded by HRSA, and they address the needs of targeted populations in a medically underserved area. So just to provide a little background on the FQHC system, and in this example, they're targeting a population, and that population they've identified have high rates of comorbid depression. They've identified that their comorbid depression is negatively impacting the ability of the FQHC to achieve the clinical quality and financial improvement outcomes that they're on track to provide. And if they're not able to address the comorbid depression, then the likelihood of them achieving improved outcomes for that same target population will be significantly hampered. And so this example is a person with complicated diabetes. They're in a value-based payment model. The FQHC is trying to improve outcomes for this person. They identify that they have comorbid depression, and that comorbid depression is limiting their ability to overcome the barriers to really meet the needs to address their diabetes. And so they're having limited adherence to their medication strategy. And so we provide an example in the toolkit in the appendix of the collaborative care management model. And that is a Medicare Part B benefit. FQHCs can provide that service and receive reimbursement. And that specifically allows, under the incident to rules, the delivery of that service under general supervision, which has a health coach that can be part of the care team operating under general supervision, that can do home visits, that can work with that beneficiary, that can help provide ongoing coaching to help them overcome barriers that address their comorbid depression, which can lead to improved clinical outcomes. The FQHC identified that without the work of the community health worker, that the clinical quality metrics on diabetes would never be achieved. They then begin to achieve those metrics, and they target that the trigger point to achieve those metrics was definitely included or addressed by the work of the community health worker. That's part of that care team. They receive additional reimbursement for that work, and that reimbursement covers the cost of the community health worker that's delivering service under general supervision according to the Incident 2 rule and meeting the specific issues related to comorbid depression that were negatively impacting the diabetes outcomes for that beneficiary or target group of beneficiaries with diabetes and comorbid depression. A value-based payment example is one where you have a Medicare shared savings, ACO, and that ACO is looking to reduce costs amongst a diabetic population. That clinic hired a community health worker promotor as part of that care team. The community health worker began doing evidence-based screening for social drivers of health. When they began doing the screening, they identified that there was a segment of the population that had a diagnosis of diabetes that were reporting to the community health worker, promotora, that they were not able to afford their insulin prescriptions. And they had been consistently not filling their insulin prescriptions because they could not afford the co-payment and afford food. And so if the clinic or the ACO is not able to support the beneficiary in meeting their need for insulin, then the likelihood that they will have a reduction in hemoglobin A1C and an improvement in diabetes outcomes for a population that clinically need insulin but cannot afford it is much lessened. So that community health worker promotor began researching how can we best meet the needs of this population of patients to have a diagnosis of diabetes and they cannot fill their insulins. They identified that there was a subsidy program, that subsidy program is embedded in the Part D as in dog, prescription program under Medicare. They also identified that there was a local resource through the Area Agency on Aging that manages the state health insurance program, commonly known as the SHIP program. And then through the connection to the SHIP program at the local Area Agency on Aging, they were able to get assistance with expediting the processing of an application to receive a subsidy for the Part D prescription program. Once they got those beneficiaries enrolled in the subsidy program, the beneficiaries were able to receive up to $5,000 in direct financial assistance to offset the cost of their insulin. Then they began to see improvement in the diabetes outcomes because there was improved adherence to the prescription of the insulin. Without this essential work of the community health worker, the likelihood that Medicare shared savings ACO would be successful would be much lessened. This example has been replicated in multiple sites where organizations have been actively screening the persons that have a diagnosis of diabetes, and then making sure that they are taking full advantage of the subsidy program that, again, I just want to highlight is very underutilized based on the need and the demands of the population. We know that there are many people that could benefit. And through this example, the community health worker made maximum use of that resource and brought great value to the ACO program to let them achieve the defined objectives of reducing costs and improving outcomes. And that was only achieved through the success of improving insulin adherence through the subsidy program. Chapter 5 goes into managed care initiatives. And there are many areas that there's opportunities for managed care organizations to begin working with community health worker CHWPs. And so we outline some of those here, and we make sure that you're aware and made aware of the policy changes that have been made available through the Centers for Medicare and Medicaid Services, so that you can understand how those are currently being deployed in your market, as well as it provides an opportunity for advocacy for organizations to begin having conversations with managed care organizations to take advantage of them. So two of them that are highlighted in the chapter objectives is the first one is the Medicare Advantage program, SSBCI. SSBCI stands for Special Supplemental Benefits for the Chronically Ill, which was established as part of the Chronic Care Act, which allows increased flexibility for Medicare Advantage plans to begin delivering non-clinical services to populations that have chronic conditions, with the expectation that they're able to get improved outcomes. The Medicare Advantage plans can incorporate that into their program design. Would they submit their model of care to the Centers for Medicare and Medicaid Services, and then they're able to deliver that SSBCI benefit. And so there's multiple examples of that, and in many markets, they are using interventions that are being deployed by community health workers that are part of a SSBCI benefit. And then there's a pathway to reimbursement for the delivery of those services for organizations that employ community health workers. Another area that is outlined in this chapter is the in lieu of benefits. And in lieu of benefits, sounds a rather strange way to call it, but what essentially it provides flexibility for Medicaid or Medicare, Medicaid managed care organizations to propose a intervention that could be delivered, or set of interventions that could be delivered to a population in lieu of other benefits that may lead to worsening outcomes for the population, with an expectation that there is a reduction in costs, or at least these are budget neutral, in that the expectation is that we will get enough improvement and reduction in total costs to offset the cost of delivering this new service in lieu of. So I'll allow you to provide a non-standard, non-clinical service in lieu of a more costly outcome that would occur if you did not provide this lower cost service. This provision to adopt in lieu of benefits is something that has now been established by the Centers for Medicare and Medicaid Services and made available to state Medicaid, and in many instances, state Medicaid allows Medicaid managed care organizations to propose their own in lieu of benefits. It's very important for organizations that employ CHWPs to be aware of this. So if you're in discussions with a Medicaid managed care plan or with state Medicaid about a new model of care, they can consider the in lieu of benefit. And a key aspect of in lieu of benefits is that they do not require a state plan amendment. So oftentimes the SPA or state plan amendment process for like an 1115 waiver, many times that's seen of as a complicated process that takes a bit of time to complete. And in lieu of benefits are established where you don't have to go through that entire state plan amendment process. It provides additional flexibility at the state and at the MCO level to do a special design of a service that's meant to improve outcomes. In many states, we see uptake of in lieu of benefits for things like addressing childhood obesity programs or healthy weight programs in children. We see them in programs to address potential low weight births or other complications of pregnancy, as well as to improve outcomes for things like medically tailored meals and other things that, if not given, could lead to worse complications and increased costs. So there's an opportunity for organizations that employ community health workers or CHWPs to leverage regulations that have been provided by CMS under the SSBCI rule or the in lieu of benefits rule in your discussions and negotiations with both Medicare Advantage plans and Medicaid managed care plans.
Thank you, Tim, for sharing your knowledge with us. Now, a question for the audience. Do you currently bill for services provided by CHW Promotores de Salud? Again, you can use Slido on your phone or by going to slido.com. If you just joined us, you can use Slido by scanning the QR code with your phone. Just scan the QR code with your camera and the link will pop up. If you have more than, I believe this is also multiple choice, if you might have yes, no, I don't know, working on it. And if you want to go to slido.com, the hashtag is toolkit. So do you currently bill for services? Majority of the group is saying no. And we have a few folks saying yes, I don't know, and some are working on it. All right, now for the crosswalk, I'd like to turn this over to Erica.
Thanks, Hanaid. The crosswalk in chapter 6, as I mentioned when I sort of walked you through the toolkit visually. This is our attempt to synthesize the information that is shared in the toolkit. So it crosswalks the reimbursement opportunities we outline in the toolkit to what would be most readily available to your organization type. So the type of CHWP. We'll look at different types of organizations such as community-based organizations, FQHCs, hospitals, individual healthcare providers, healthcare practices, and crosswalk those to different potential reimbursement strategies that they may be able to leverage to support CHWPs in their organization. So we'll look at incident 2, managed care contracting, or value-based payment participation, for example. And then I think I'm turning it over to Tim to talk through chapter 7.
Great, thank you. So one of the key aspects of a community health worker CHWP program is to really understand the contracting cycle. And so we provide some information in chapter 7 that really speaks to the contract capture process, where we wanted to provide tips and guides to help you understand the components of a successful negotiation with a payer. So for the use of this model is really looking at, I have a program, I know that my program can drive improvement. And so now I want to package that in a way where I can present it to a payer and then successfully negotiate to have this intervention adopted and incorporated into the payment model. So we provide some things that should be thought of to establish a robust strategy that includes identifying the target population. For example, I gave the example I gave earlier. I may be looking at the population of women during pregnancy, maybe looking at childhood obesity or falls in the older adult population, persons that have a diagnosis of diabetes or pre-diabetes, persons who screen positive for food insecurity. So really honing in on what that target population is, establishing what those services that I want to incorporate into the model. I would really recommend looking at the role of social drivers of health, implementing evidence-based screening tools, beginning capturing what are those high priority needs within our population and tailoring interventions to meet those needs. The hypothetical example I gave earlier was looking at a population with a diagnosis of diabetes. And then that model, they established a targeted intervention to improve adherence to insulin for that population. So that's an example where we had a target population, identified a set of services. Those services were spearheaded by the CHWP. They're establishing what that referral process is. Oftentimes, when I have an opportunity to work with community-based organizations or community care hubs that organize a network of community-based organizations, we speak in great detail in planning on that referral process, because we integrate that with healthcare providers or health systems. We want to have a streamlined process to facilitate referrals from clinical settings to CHWP organizations, capture those referrals, document the need, implement the screen, and then deliver the targeted service. A segmentation strategy is also a great way. And so we incorporate this information as part of it. And an example of a segmentation strategy is where we may look at roster billing, where we could begin targeting, if I'm going back to the population that have a diagnosis of diabetes, or may segment the population to say everyone who has a hemoglobin A1C greater than 7, and then begin identifying based on zip code data where there may be a coinciding need based on an area deprivation index score. And an area deprivation index score is something that was developed by the National Institutes of Health, and that data is maintained at the University of Wisconsin. So anyone can look at that data, and it tells you areas based on zip code that have a high area deprivation index, where there's a greater likelihood that those persons would be negatively impacted by social drivers of health. That can be incorporated into your market segmentation strategy, and then implement a roster referral process where we receive referrals from everyone that resides in an area that has a high area deprivation index. And then we could then have a targeted implementation strategy to deploy interventions to meet those needs. So we make sure that you understand those key fundamentals as part of this, so that you can have it incorporated into your market negotiations with a potential payer. You absolutely do need to also establish what the expected outcomes are, have a method to track your achievement or lack thereof of those expected outcomes, because that's key to establishing the return on investment. Return on investment and the analysis of that, or the evaluation, should have clinical and non-quantitative measures. So there'd be quantitative measures where we're looking at specific clinical markers like improvement in hemoglobin A1C, improvement in adherence to medication, but also qualitative measures like beneficiary satisfaction, other things like that are things that we should track and have that reported and be part of the expected outcomes, so that there's a clear way to track the return on investment from the purchaser of services that would buy the services from the CHWP organization. You have outlined a specific method to track the intervention, track the deployment, and track the outcomes, and evaluating the impact. So we provide the outlines of this to make sure that you consider each of these key learnings and have that incorporated into your overall strategy to increase the number of contracts that you're able to incorporate a CHWP intervention into the model.
Okay, thank you, Tim, for that great description of those contract capture strategies. Many of those checklists and things that Tim just described are available in the appendices. I just want to highlight some key appendices for you. Appendix C are the categories of services for organizations employing CHWP. So this is a critical appendix to the toolkit. It references, those services that are included in the reimbursable set of services under the original Medicare program, and that other payers and health plans can adopt similar services and codes. And so that's a really critical appendix. In addition, we have tips to becoming a Medicare enrolled provider for those organizations that may not be. And then those appendices F through K really dig into what Tim just described and provide checklists and guide you through the process of developing a strong contract capture strategy, as well as entering into negotiations with the payer. So that's really some concrete tools that we wanted to provide for you to help capture some of these these revenue sources. And then Appendix L outlines those examples that Tim went through earlier in the presentation for how to incorporate CHWP costs into both a fee-for-service and value-based payment structure. Those are included in that appendix for your information as well. That concludes our presentation of overview of the toolkit. I just remind everyone, please put questions into Slido using the hashtag toolkit. We're going to have a Q&A discussion at the end. So any questions that you have for myself or Tim, we'll be able to address at the end of the webinar. Now, I'd like to introduce Dr. Manuel Solano. He's a director of behavioral health at Samuel L. Rogers Health Center, which is a federally qualified health center in Kansas City. Dr. Solano was on our advisory team, advising on the content and development of the toolkit. First, when he was at the Community Health Council of Wyandotte County, which is a community-based organization, and now in his new role with Sam Rogers, or not so new anymore, but now in his role with Sam Rogers. And he's going to talk a little bit about, we're going to have a discussion about how, what he likes about the toolkit and how the uses he sees for the toolkit in his work and how it can inform the sustainability and growth of CHWPs in his organization. So we'll go to the next slide. Okay, Dr. Solano, hello. I just don't know if you wanted to say a few words before we have a discussion and I ask you some questions.
Just a quick note. Number one, thank you very much for having me here. And the second one is misspell correction. That is Samuel U. Rogers, not Samuel L. Rogers. So, so that's a small correction in there. So thank you very much. And thank you for inviting me. So go ahead.
Thank you for being here. So as an advisory team member and someone who's actually been involved with the collaborative for since I think it started, and has some knowledge of all of the work we've done to help sustain community health workers in our region with this new tool that's available. What do you like best about it? What do you think is best about this toolkit for our community?
Well, first of all, I'm biased because I have been part of the project and I learned a lot from you, from the team, and it has been very, very important learning process and developing process. So it's really nice to see how this toolkit is now available for everybody. It is especially rich. It's a lot of information, what the work that you and Tim put together is very, very important. The two of you talk about this toolkit in 40 minutes, 45 minutes, but for me, it took me months to go through everything that is in there because it's so in depth and so detailed, and there are so many correlations between the parts of the toolkit that is impossible to understand the value of the toolkit unless you read it and understand the correlations inside. So for me, what is the best about the toolkit is that number one, it provides the scope of the work for the community health workers and prevents a lot of misconceptions among the administrators and among the different professions, especially nurses, community licensed social workers. So what is the scope of the community health worker, and having a tool like this describing and limiting and clarifying the scope is very important. That correlation and correlations like with the chapter 4, chapter 6 and 7, how can you charge for those services and how are those services different than other providers? That is very, very important. So for me, the best is the scope of the services that the community health workers provide.
Thank you. Thank you so much. It's great to hear that that's been very useful for you in that way. I think an intent we had was to be very clear and ground the toolkit in the scope of work. So it's nice to see that came through and it's been useful in that way. Can you provide examples of how you've used or plan to use Appendix C, explore using Appendix C in the toolkit?
Absolutely. Appendix C for me is very, very important, but you cannot work in Appendix C without understanding chapter 4, because there is a big correlation in there. So don't jump into into Appendix C, especially if you're thinking about payers and understanding and trying to understand how to charge for these services without being careful about reading chapter 4, and I would say 5 and 7, because you need to understand what a care management organization does, what are the scope of the services, the differences between Medicare, Medicaid, what is applicable to your particular state, location, and so it is in the air. The toolkit has no value, but if you tie that to your specific needs, to your specific location, you can use that in a very productive way. For me, and when I was at the Community Health Council in Kansas, something that they allowed me was to categorize the services of the community health workers, the different categories of the services that they can provide. And a big one, for example, that is applicable in many, many scenarios is education. And I don't want to talk about codes. I'm not an expert in codes, but you can check and look for the codes that apply at your particular level and can be billable. So find the categories, identify the categories that you may need. Can be education, can be health, but the association, for example, between depression and anxiety with the accumulation of chronic conditions is high, up to 40%. And if you go male, female, there are a lot of correlation in there. So you can, as Tim was mentioning when he explained it, chapter 7, you can find those correlations and what are the categories that you need. In the Appendix C, you have like step-by-step examples about, okay, what do you do if you have a behavioral health integration scenario? This is what you can do. What do you do if you are trying to think about Medicare? And what is the difference between thinking about negotiating this with straight Medicare or a care management organization, Medicare Advantage? So there's a lot of lingo in there that the two of you just mention it, but when you go in depth, you need to understand those terms in order to be able to even start thinking about billing. So for the tool, and one of the important things of the tool is that it explains in detail those correlations.
Thank you so much. And I think you've made some really great points. For example, you're right, the toolkit is all linked. Chapter 4 is critical to understanding before engaging in Appendix C. And so it's been written as a step-by-step guide to help at all levels of understanding. So thank you so much for that description. I know you and I have talked quite a bit about how to use the toolkit, and some of what you shared is, this is a great starting point. You have to understand your local environment as well. So can you share some tips for this group in terms of if they embark upon using this toolkit and for themselves?
Absolutely. Using this as a resource, and for me, I'm going to just limit in this particular example for chapters 4, chapter 5, and chapter 7, because there you have information that if you have the specific definitions of the scope of the services that your community health workers can provide, and you have the categories of those services, you can use these chapters and Appendix C to go to a payer and tell them, hey, I can reduce your cost in the long term. Tim gave us very beautiful examples, but you have to take those examples and think in your specific environment. For example, one thing that can be done is there are payers at the levy in the local government that support behavioral health. And even though I'm going to use Tim example for this one, diabetes, without addressing the barriers to care and the social determinants of health, it doesn't matter how much medical care they have. If they do not have the social care and the social determinants of health are not addressed, the A1C will never come down. So you can talk to them, and using the definitions that are in the toolkit, you can create categories. Something that for definitions, I copy categories from the levy, our local levy, and they have categories like case support, case management, case integration, crisis management. So once you create those categories, you can start thinking and negotiating with payers. And in the long term, this is there's enough research, and the toolkit shows that how you can save money, and you are saving money. You're muted.
Thank you. Thank you so much. We appreciate you sharing your expertise, your time, and your knowledge about the toolkit with our group. Would you mind staying around to answer questions? If we're going to now move into the Q&A question portion, I'll turn it over to Hanaid to facilitate kind of opening that up.
Thank you, Erica. Thank you, Dr. Solano. So we want to give everyone an opportunity to submit their questions. If you haven't, you can scan the QR code again with using your phone, the camera. You'll see a link pop up. You can go ahead and click on there and enter your question. If not, you can click slide. You can go to the URL slido.com. The hashtag is toolkit. The questions can be submitted anonymously, so we will not know who's asking this question. As you can see, we see anonymous on there. So we'll just be able to read the question, and then Tim, Erica, Dr. Solano will be able to respond to those. So yes, just giving folks a few seconds to, as you're developing questions, as you heard the different topics in the webinar, as well as the section right now with Dr. Solano and Erica, just giving them a few seconds to be able to come up with questions. Okay. And if anyone has trouble using Slido, please let us know in the chat so we can help you with that.
I think while people are typing, if we could have maybe, I think there was a question about FQHCs. It was asked a couple times in there.
Yes, there's one right there.
About collaborative care management. I guess we could just make our way down.
Right, and I'm not sure if it moved. Is it that one? Are there FQHCs in Missouri billing for CHW services? What payers are they able to bill?
So I could not say which FQHCs are billing for CHW services, but I'll let Tim take the second part of that question, if he doesn't mind, in terms of what payers are they able to bill.
Sure. So under the rules for Medicare Part beneficiaries under Part B as in boy, community health workers, federally qualified health centers are allowed to bill for chronic care management and collaborative care management. Both of those interventions allow for the services to be delivered under the Incident 2 rules that also support general supervision. There's a specific payment rate for FQHCs. I'm saying FQHCs, this also applies to RHCs or rural health centers. They're both under that authority, able to bill for those services today. That rule change to specifically allow FQHCs and rural health centers to deliver those services was enacted a few years ago, and it includes the example I gave of collaborative care management, where it is a care management intervention to address the behavioral health needs of a person, and it can be billed under primary care and is separate and distinct from specifically providing mental health service. So, for example, the community health worker operating under general supervision of the care team could be working with a beneficiary to improve adherence to their appointment schedule with their psychiatrist, or overcoming individual barriers in their home setting that are negatively impacting their behavioral health. They could do it under a behavioral health integration model, and then that could be billed under an FQHC or rural health center, and the regulations specifically allow for that.
Thank you, Tim. Are there guidance and resources on developing, defining scope? So I'm going to assume this is the CHWP scope of work. I'm going to actually ask Dr. Solano to jump in here. I would say in both Missouri and Kansas, there's an adopted scope of work, and the certification process for becoming a certified CHW lists that scope of work as well as the core competencies that a CHWP must have. But I think I'll let Dr. Solano kind of jump in here.
I think
he has experience really implementing this.
I think you just answered the question. We have, and the coalition has been working a lot on this, and with the help and guidance of the team, the coalition has the word, and there is a lot of resources in the website for MARC and the Community Health Worker Coalition where you can find the guidelines to developing and defining a scope. And in any case, if you take the class for community health workers, the actual curriculum for Missouri and Kansas, they are based on competencies. So they are very specific. They define the scope, and the coalition has the scope of the services too. So this is a work that has been in progress, and it was very difficult at the beginning to standardize those and find an agreement in the scope of services, and especially not touching and stepping on anybody's toes. But I think what the toolkit offers, and if that is not enough for you, you can check in the MARC website and the coalition website, and you will find anything that you will need.
Yeah, I would add to that, the training, there's kind of recognized trainings for the certifications in both Kansas and Missouri, and that really helps a community health worker to develop their scope of practice. And in addition, we've developed supervisor trainings, which are actually critical for within a clinical setting or in a care team setting, supervisors being able to manage the deployment of the CHWP and helping the other providers in that care team understand the CHWP scope of work and their role in the care team environment. So that's another critical resource, I think, that helps in terms of implementation. Tim, can you take the question about incident 2, the top one on the screen there?
Absolutely. So the question is, for incident 2 billing, can you give an example of operationally what type of provider supervision is given to CHWs to count as incident 2? So specifically, the provider type that can deliver supervision under the incident 2 rules includes a physician or non-physician provider. A non-physician provider includes things such as a nurse practitioner or a physician assistant. And so operationally, how that would work is, let's take the FQHC example. I am Dr. Tim working in a fairly qualified health center, and I have a patient who has, let's move from diabetes to congestive heart failure. And this person has congestive heart failure, and they're having significant challenges with the diet restrictions, and they have food insecurity, and they're not able to understand how they can use the limited financial resources they have to meet the dietary restrictions that have been placed on them for their congestive heart failure. I then provide some written instructions to a community health worker. That community health worker goes to the home. That community health worker then reviews the diet restrictions that have been written by the physician with the beneficiary, goes through what types of foods the beneficiary has, helps them with budget planning, helps them apply for SNAP benefits, and then assists them with identifying through food bank and other avenues, ways that they can have better, healthy diet choices that meet the requirements of the diet restrictions that was established by the physician. Under that scenario, that physician is providing general supervision to the community health worker that's deploying an intervention outside of the clinical setting to achieve those outcomes. So that's the community health worker is operating incident to that physician who provided the instructions, but as an extension into the community, the knowledge, feedback about the challenges that beneficiaries facing would not be under the purview of that physician without that extender, that community health worker that is really targeting the needs of that beneficiary, matching it, delivering, capturing their time, and then we're able to bill for that as an incident to service under the chronic care management requirements.
Thank you so much. If anybody has follow-up questions to that, please put them in Slido, but that was a great description of that. Thank you. Is there guidance on billing rates for CHWP services, and how would those be determined? So I think, Tim, would you want to take that? I believe that's a negotiation between the payer and the organization largely. Is that correct?
It absolutely is a negotiation between the payer and the organization. But in order to go into that, and we covered this in the contract capture negotiation tips, you as an organization need to understand what your costs are. You need to also understand what is your cost of deploying that intervention. And that community health worker has some incremental costs that it's going to take in order to deploy that intervention. And it's impossible to negotiate what your rate is if you don't have full awareness of the cost. And you want to leverage economies of scale as much as possible. So volume is also very important. You want to benchmark that to standard rates in the fee schedule. And so I'll give you an example. I was working with an organization that was negotiating a rate for community health worker intervention. And they defined that intervention and said, well, we want $500 per intervention for the community health worker. And I told them, realistically, does the payer pay $500 for the physician to do a similar service? So if they wouldn't pay $500 for the physician to do an intervention, what's the likelihood that one, it really costs you that much, or that you will be able to obtain that level of reimbursement? So you also need to, it's almost like purchasing a house. You want to have some comparable markers in the marketplace that you target your intervention to, as well as the cost, and then you determine how to deploy it.
Thank you. Great description.
Let me add something here. Okay, it's very important for all of us to understand that the law is the big umbrella that covers absolutely everything. And we need expertise, somebody who understands the law, all the processes, understands the payers, understands the insurances. So don't jump into the conclusion, oh, because I heard this and I participate in this webinar and I have toolkit, now I'm going to be able to bill for something. It is a complex process. You need to really understand the law. Tim has been very specific, but in order to manage the quality of the services that he has been talking about, and to have that level of expertise is very complex. So just don't take that light, please.
Yeah. Thank you. Yes, and I think that sort of aligns with your tips for how to use the toolkit. Understand your local environment, your local payers, and what is required locally. Okay.
Can I address that next question there about can only FQHCs? So I want to really highlight and hammer home this concept that chronic care management and collaborative care management were initially established as Medicare Part B as in boy benefits. And any provider that provides Medicare Part B services or services beneficiaries can bill for chronic or collaborative care management. But just like Dr. Serrano says, you have to do it according to the regulations. So you have to understand the regulatory environment to deliver that. However, that Medicare Part B regulations apply to FQHCs, rural health centers, but all providers that are enrolled in the Medicare program. And the nice thing about the fact that it is a Medicare Part B benefit, there's a statutory requirement that all Medicare Advantage plans cover all services that are part of Medicare Part B. So now if I am in discussion with a Medicare Advantage plan, and I know this is a Medicare Part B benefit, then that increases my leverage in negotiating with the Medicare Advantage plan because I know this is a covered benefit for all Medicare Advantage beneficiaries. So it's something that extends far beyond just FQHCs.
Yeah, absolutely. Thank you.
Quick comment.
Yeah.
Or a question for both of you. Tim, can you explain a little bit the difference between a straight Medicare, Medicaid Advantage, Medicare Advantage, and all the other Medicares? Because we may have the tendency to assume that they are the same.
Sure. So there's people that are enrolled, and this is actually the majority of the population that are eligible for Medicare. And you become, and there's more detail about this in the beginning of the toolkit, but you become eligible for Medicare based on age or disability. So oftentimes people think of Medicare as just for older people, i.e. over 65, but there's a significant percentage of the population that are eligible for Medicare due to a disability and are under age 65. So if you have a permanent disability, i.e. you're eligible for SSI and other things, and there's other qualifying factors, then you could also be enrolled and eligible for Medicare. Once you become eligible for Medicare by age or disability, then you have the option each year to enroll in a Medicare Advantage plan, or Part C is in cat plan. If the beneficiary enrolls in a Part C plan, they have opted to allow a managed care organization to manage their Medicare benefits. One of the reasons that people may do that is because under Medicare Part B or original Medicare, there is a co-insurance requirement or cost sharing where Medicare pays 80% and the beneficiary is liable for 20% of the costs. In addition to that, there are required deductibles and annual payments that you have to make. Sometimes organizations or persons are able to get those things waived if they enroll in a Medicare Advantage plan. And separate from that, that is something called a special needs plan. And in many states, there is something called a dual eligible special needs plan, or DSNP. And that is a plan specifically for people who are eligible for both Medicare and Medicaid. And those plans usually manage beneficiaries who have more complex needs. And you have to understand the different payer landscape so that you can effectively negotiate for your role in the delivery, as well as understanding the payer mix of the population that you want to provide your community health worker intervention to.
Thank you. Okay. Are we seeing the latest questions here? So I think we're going to have to wrap up soon, but we are planning to release an FAQ document based on the questions we receive in Slido. So if you do continue to have questions, please put them into the Slido tool, because we will answer them even if we run out of time.
So I see something there at the top, right? Do you have any example of a state that allows CHWPs to bill Medicaid? What services are they billing? So we do have multiple examples, and I had the luxury of working with multiple states. And so very recently, there were some states that announced that they just got approval for their 1115 waivers. And that includes Oregon and Massachusetts and Rhode Island. And those states specifically incorporated community health worker interventions as part of a state plan amendment for 1115 waiver that allows for the billing of those community health worker interventions to Medicaid. And separately for that, we have multiple examples of states where they've incorporated a community health worker intervention as part of an in lieu of benefit that also can be reimbursed by Medicaid. Some of those include, like in New York State, where there's specific interventions that can be delivered as an in lieu of benefit, and Medicaid managed care plans are reimbursing that under the Medicaid program.
Thank you. In the next question, Tim, do you want to take, maybe we'll take this in payment models where provider has to generate the care plan. And with the medical system shortage, how do we get providers to buy into the model? We'll take that one. And then the question about CBO's help for billing and navigation. I think we'll try to get at least those two before we wrap up. And maybe the next one. Okay.
So that's a great question. So in payment models where the provider has to generate the care plan and there's a medical system shortage, how do we get buy-in? Well, one of the things that is very common in healthcare that we have to continue to remind providers about is that the best practice approach is the deployment of a multidisciplinary care team. So under a multidisciplinary care team, all members of the care team contribute to the care plan. So I'm not totally dependent on the provider to write all aspects of the care plan. Me as the community health worker, particularly if social drivers of health are a major impediment to health outcomes, I can actively contribute to the overall plan. And then the provider can review my input and then consolidate that plan. So I am contributing, assisting with the completion of the plan. Me as a community health worker is not totally owning the plan, but significantly contribute to it, particularly in my area of expertise. The area of expertise that a community health worker has that in many instances is superior to the provider is the intricacies on addressing social drivers of health, as well as understanding the complex lives that many beneficiaries that are negatively impacted by social drivers of health live, and then establishing a plan to overcome those barriers. So we have multiple examples of that, and particularly in hospital settings, when you look at things like homelessness and other things, the ins and outs of how to address housing insecurity, food insecurity that directly contributes to health outcomes, a community health worker can have a significant impact in the overall plan, which is then overseen by the provider. So that's how we address the provider shortage and get the buy-in, because we're assisting the provider to achieve those outcomes.
Thank you. Tim, I think we can take two more questions. So the next two on the screen, would you want to tackle those for us? Oh, they switched. Okay, I was going to do resources for community-based organizations, and then the bottom one, so CHW services would be billed under CCM, behavioral health integration, collaborative care management, et cetera. Can we maybe tackle those two?
Sure. So it is a resource for community-based organizations to help set up billing and navigate the options to bill. So this toolkit was our attempt to provide an initial resource. We want to highlight that we really expect this to be an interactive living document. So we want your feedback. We want to know, are there areas where we could expound upon? Are there technical assistance areas that you really see as critical to moving this forward? Because we want to be really a national resource to help push this, because it really is like a rising tide lifts all boats. If payers are operating in multiple states, if we can really get broad adoption of this, it really helps everyone. So we really want to highlight this as an initial resource, but a living document that we help support and assist in the modification to meet the needs of the marketplace ongoing.
Yeah, thank you for mentioning that. And because Tim's right, we see this as a living document, a first step. We hope to continue with technical assistance and further, hopefully, learning collaboratives based upon this document. Okay, Tim, the next one there on the top of the screen, please.
Oh, the top of it. Community health worker services would be billed under CCM, which is chronic care management, BHI, which is behavioral health integration, or COCM, which is collaborative care management services in the FQHC, Kansas and Oklahoma FQHCs. So yes, CHW services can be, it's not the only pathway, but it is one pathway where you can, community health workers can deliver services using the incident 2 rules that allow for general supervision, specifically tied to collaborative care management, chronic care management, and behavioral health intervention and integration, And there is a specific rate for FQHCs to deliver these services. They are time-based services. I believe that the FQHC rate is very favorable for community health workers to deliver this. And then it is a Medicare benefit, Medicare Part B. And so oftentimes, because I also work quite a bit with federally qualified health centers and rural health centers, and I do fully understand that FQHCs, the majority of their population may not be Medicare. In fact, in many instances, less than 10% of the population at FQHC may be Medicare, but it's a place to start. So let's not discount that 10%. If we can begin to get really comfortable and adept at delivering this model, at least for our Medicare beneficiaries, we then have leverage to go to the Medicaid managed care organizations to present this model. There's existing codes for these services. These codes are all in the CPT code set. So the American Medical Association, which has the copyright ownership of CPT, has established these in the CPT code set. We provide the Medicare Learning Guide that's in our appendix that outlines what the codes are, and it begins a starting point. So now, if you piece the concepts together for those that are going to use the toolkit in an advanced way, we provided information around in lieu of benefits that are available to Medicaid managed care organizations. And we also are providing you with the code set for chronic care management, collaborative care management, behavioral health integration, as well as the incident 2 rules that have been specifically modified to allow these services to be delivered under general supervision. Now, I, as an FQHC, network of FQHCs, primary care association of FQHCs, could very well approach Medicaid or Medicaid managed care organizations and say, we want to expand our delivery of chronic care management to Medicaid beneficiaries. We want to use the in lieu of leverage that has been afforded to Medicaid by CMS. And what codes will we use? We're going to use the CPT codes that were established by the American Medical Association, which provides the clinical evidence for the value of these codes. There's something called RVUs, or relative value units, that have been established to benchmark the costs. And now I have benchmark rates, the costs. I have the in lieu of guidelines that allow me to negotiate with Medicaid. And I have experience delivering this with a Medicare population, which allows this hypothetical primary care association of network of FQHCs to successfully negotiate with Medicaid plans in my state to allow me to bill for chronic care management as an in lieu of benefit using the same CPT codes that have been approved by AMA. And then now the FQHC has one model of care that incorporates across their entire beneficiary pool.
Mm-hmm. That was a great response. Thank you so much. I think that's a great last question, place to end for our Q&A section. So thank you so much for that. Again, we will post a FAQ document based on all the questions we got, even the ones we haven't answered. But I will turn it over to Hanaid now to wrap us up and wrap us up for the day. So thank you, everyone.
Yeah, thank you so much, Erica, Tim, Dr. Solano, for taking the time to respond to those questions. We will get to them as well. This is one last question for the group using Slido. So based on today's webinar, do you have suggestions for further discussions, kind of the things that we talked about today, the possible topics? Again, this will be multiple choice, so you can select more than one option. What is your interest? Would it be maternal and child health, a FQHC perspective, CBOs? Again, you can use Slido by scanning the QR code with your camera on the phone. You can also use slido.com using the hashtag toolkit. You can select more than one. So again, CBO challenges, Medicare value-based payment, learning collaborative opportunities under the original Medicare plan. All right, we see that CBO challenges and FQHC are the top 2 for now. Wonderful. Thank you folks for voting. Yeah. All right. Thank you. All right, now this one, I know that we gave you some options where you can select more than one, but this one's kind of free text. So if there was a topic on there that we didn't mention, is there something based on today's webinar that you have suggestions that we could offer? So something that you want us to elaborate a little bit more. So this one is, free response. Tell us what you wanted to hear more about, go more in depth, offer maybe a part 2. Something that was, again, not in the list of options that we provided earlier. So if you want to take a few seconds to enter something so we can see your responses there. And we're also getting feedback. Thank you so much for being here. A part 2 of this. Okay, integrating teams with CHWs, healthy aging. Maybe making this kind of monthly, a deeper dive on portions of the toolkit. And we'll provide information in the next slide of where you can email us if there's a deeper dive specifically that you want us to go through the toolkit. You can let us know which section. A class on how to use the tool. Okay. More training on doula work, birth work. Wonderful. We have people typing. All right. So again, thank you so much, everyone, for being here today. We want to thank the Help Forward Foundation for making this possible as well. So next steps, I know that we had some questions in the chat about it. We're going to email you a link to the evaluation. We also recorded the session, so we'll be able to record it, upload it to YouTube, and then send you that link so you can view it and share it, as well as we shared the link to the toolkit. It's published on our website. We'll send you the direct link so you can access it as well. And then we have a website, our email, where you can send us additional questions, feedback, chwinfo@mark.org. If you have questions about the toolkit, suggestions on how to improve it, future webinars, different content that you want to see. We also had questions about if, supervisory series or upcoming content for CHWs. If you want to be added to the distribution list, if you haven't received any of those emails from us, please also email chwinfo@mark.org to be added to that list. And our plan is to release an FAQ document based on the questions and comments received. And we really want to thank everyone today. Erica, Tim, Dr. Solano for being here. Everyone in the audience, thank you so much for participating, as well as support. I know we have folks in the background. We have Michael and Shelly that's been helping us, and everyone who was able to attend. We know this webinar was hopefully as exciting because it's I feel like there's a lot of new things that we learned today. So again, thank you everyone so much. And we hope that you're able to, I know Dr. Solano mentioned that he spent hours or days, I don't know how long, in this toolkit. So hopefully everyone's able to spend more time reviewing these on their own. And just thank you so much for being here today. And we hope to see you next time in the next webinar. Erica, Tim, Dr. Solano, I don't know if you have any other comments.
Thank you very much, and look forward to use the toolkit.
Wonderful.
Yeah, I'll just say thank you for everyone being here. We look forward to your feedback, and a special thanks to Tim McNeil for his expertise in helping to create it. We really couldn't have produced this document without him. So thank you, and thank you for being here with us today.
Great, thank you all. Your feedback is very much welcome. We really want to make this as user-friendly as possible. So please, please, please share your feedback so we can continue to make this a very useful tool for all.
Yeah. Thank you.